My name is Jonathan Wang, and I'm the founder of the Youth Advocates for Global Health Association.
And my name is Matthew Yu, the Vice President and co-host of our organization.
Youth Advocates for Global Health Association is a non-profit led by students passionate in the medical field. We connect students worldwide with healthcare professionals and global health experts in person and online. Today, we are thrilled to welcome everyone to the first medical webinar in our series, where we will explore the topic of global health equity. We are delighted to have Dr. Rose Leishman from Doctors Without Borders with us today as our guest speaker.
Dr. Leishman earned her Doctor of Medicine from the University of Calgary in 2019 and completed her Family Medicine Residency at the University of British Columbia in 2021. She holds a Bachelor of Science with honors in Kinesiology from the University of Victoria and has gained experience as a hospitalist with the Island Health and Alberta Health Services. She's worked as a clinical instructor at the University of British Columbia. Most recently, Dr. Leishman returned from 6 months of working in the Central African Republic with Doctors Without Borders.
We are excited to have Dr. Leishman share her insights with us today, so we encourage everyone to turn on the cameras if possible. Following the presentation, we will have a Q&A period, where all webinar participants may type the questions in the chat box.
Let's give a warm welcome to Dr. Leishman. Thank you so much for joining us today.
Thanks so much for having me. And thanks for the introduction. So, as you both mentioned, I recently returned from my first assignment with Doctors Without Borders. Throughout the presentation, I'll refer to the organization as MSF, which is just the acronym for their French name, Médecins Sans Frontières. And I will start just by talking a little bit about MSF as an organization, and then we'll jump into my experience in the Central African Republic, or CAR. So MSF is an international organization that was founded in 1971 in Paris by a group of doctors and journalists. We provide medical humanitarian aid all over the world, and we go wherever the needs are greatest. Just a few stats about MSF. So you can see on this map here the countries that MSF works in, and all of the data that I'll share in this presentation is from 2023. So as of 2023, MSF had active projects in all of the countries highlighted in red. That's more than 75 countries around the world. We have over 69,000 staff worldwide. About 55,000 of them, or 80%, are locally hired. And all taken together, our staff represent over 160 different nationalities. So many people are working in their home countries with MSF, but then there are many more people from around the world who travel to work as international staff on projects. MSF is really, we do all our work centered around 5 key principles. The first is impartiality. So we offer assistance to people entirely based on need, and not based on where they're from or the color of their skin, their religion, their political affiliations, which side of a conflict they're on, gender identity, sexual orientation. None of that comes into play when MSF decides where we're going to work. It's all 100% based on medical need. The second principle is independence. So in order to remain impartial, we work very hard to be entirely independent. And that means independent from influence from donors, from governmental organizations, other NGOs, intergovernment organizations. And the way that we maintain our independence is primarily by being funded mostly by small donors from all over the world. We essentially don't take any government funding. There are some very small exceptions to that, but basically MSF is funded entirely by individual donors. And individual donors are not able to earmark funds. So what that means is if there is a conflict or a disaster somewhere in the world and a whole bunch of money flows in, If it were earmarked, if donors were able to say, we want our money to go to tsunami relief in Thailand, then MSF would be committed to putting that money there, even if that wasn't the place that had the highest need. And so MSF for many years now has not allowed earmarked donations, and that allows us to be totally independent and to make decisions based on need and not based on kind of what's popular or what is getting the most attention in the media. The third principle is neutrality. So we don't take sides in armed conflicts. We don't support the agenda of warring parties. Because of our principles of impartiality, we just provide care where is needed. And so that is not necessarily present on all sides of the conflict. So a good example right now would be the Israel-Gaza conflict. MSF is one of the primary humanitarian organizations providing relief in Gaza right now. And that's not because we take the side of the Palestinians or of Hamas, but because Israel has a robust healthcare system, and they don't need the humanitarian that MSF is providing. So again, it's totally need-based, and just because we're on one side of a conflict doesn't mean that we are partial to that side. We remain impartial in all cases, but sometimes just because of need, we end up on one side of a conflict and not another. The fourth principle is bearing witness. As I mentioned at the top, the founders of MSF were not just doctors, not just medical personnel, but also journalists. So from the very beginning of the organization, it's been a strongly held principle that not only will we provide humanitarian relief, but that we will speak out about the humanitarian crises that we see in order to gain more attention and gather more help and resources for the populations that we're serving. And the last principle is transparency and accountability. And that all comes down to being transparent about where our funding comes from, where it goes to, and what we're doing on the ground. So we have a huge amount of the organization is dedicated to collecting data and then disseminating data about what's happening in the project. So every single project around the world has, is collecting data and then sending that data back to the operational centers who disseminate yearly reports with really detailed information about everything that we're doing.
Right. It's truly inspiring to hear about MSF's commitment to, equal and neutral medical care. So I was just curious, like, what motivated you to join the organization?
So before I went to medical school, I had in my mind that I wanted to become a doctor and to do international work. I had done some other kind of like international things before I started medical school. And so I was just interested in working in that space and in low resource contexts. And then in medical school, I did at the University of Calgary, there's like a kind of parallel curriculum that you can elect to be part of, which is in global health. And so I did that as part of my medical training. And then I also did some training at the University of Geneva in global health. And I just really enjoyed that work. Like, I find it really interesting. I think it's obviously for many reasons very different than doing clinical medicine in Canada, not just because often the resources are very limited in these places, but also because there is a whole like cultural, political, geopolitical component to it that is just totally different than what you experience working in Canada. So yeah, I just really enjoy that side of the work. And I thought that I would enjoy that. So that's kind of how I got into it.
Right. Wow. Awesome. So just wondering, like, if of all places in the world, why did you choose the Central African Republic? Was it
Yeah.
somewhere you got assigned to, or is it somewhere you just wanted to go?
That's a great question. So when you get hired by MSF, you get hired to be part of their talent pool, essentially. So they kind of have an idea of how many doctors they need and how many nurses they need and how many logisticians and engineers and how many people they need with these different profiles. And then, so when you get hired, you just get hired into a pool of people who they can tap into at any time. So when I got hired into the pool last late July or early August, and then I was really keen to go out on an assignment right away. And then the first assignment that came up, there were two. There was this one in CAR, and then there was another one in South Sudan. And for various reasons, the South Sudan was like not really compatible with my clinical expertise. So I ended up taking this one. It was just the first best one that came up. But you can, like when you can always say no. So if for any reason you're not comfortable going to a certain place, whether that's for security reasons or any other reason, you can say no. So you do have choice in that way, but most people pretty much go wherever they're offered an assignment because yeah, I mean, MSF has, we can talk about this later, but has pretty robust security protocols and things like that. So everywhere you go carries a risk, but with few exceptions, most places kind of carry a similar risk. And so most people just go wherever they're assigned.
Yeah, that's cool. I think we can move on, hearing about Doctors Without Borders in the CAR specifically.
Sure. Yeah, so this is a map of CAR. It's right in the middle of Central Africa. So if you had the continent of Africa on your wall and you threw a dart right into the middle of the continent, you would hit CAR. It's landlocked. To the north, there's Chad. To the east, there's South Sudan. To the south, the Congo. And to the west, Cameroon. And that kind of locality of countries, so the Congo, CAR, Chad, South Sudan, these are four of the least developed places on earth. So it's a pretty isolated and remote place. And I was in Carno here, which is in the west of the country. And I'll try to be really brief about this, but just to give you a context of kind of the geopolitical situation in CAR. So it's a country of about 5 million people. It was a French colony and gained independence in the 1960s. So it's been independent for about 60 years. And for those 60 years, really, there's been basically constant civil war. And there was a period of quiet in the mid-2010s, but in late 2020, early 2021, there was an election process that was contested by rebel groups throughout the country. And since then, really, there's been fairly active conflict between the rebel groups and the government. So the capital city is Bangui here, and all of this red territory is government-held territory. And then all of the other colors there are just territories that are held by other rebel groups. So you can see that Carno, where I was like really deep in government-held territory. So it was a relatively calm part of the country. I didn't see any active conflict while I was there. But in the east and the north of the country, it's a much more precarious security situation. And really the whole country is precarious to some degree. Like it's just a very unpredictable place. The government has its own military, and then it's also supported by the United Nations. There's a United Nations peacekeeping force essentially that has been in CAR for quite some time to try to support government stability. And then also the government is supported by the Russian Wagner militia group. So they are present in the country. It's very interesting when you land in Bangui and there are all these local people, there are no tourists, and then there are UN employees, NGO employees, and Russian military operatives. So it's a pretty interesting place. The decades of civil war in CAR have led to extreme poverty, massive displacement within the country, and also displacement out of the country, and one of the lowest access rates to healthcare in the world. Again, these stats are all from 2023, and last year, 3.4 million people were in need of humanitarian relief, so that's more than half the country. 30% of people have access to clean water. It ranks 191st out of 193 countries on the Human Development Index, and less than 50% of the country's healthcare facilities are currently functional. And that's really just because of all the war that has happened. The government does not have a lot of resources and is not very stable. And also the education system is not very stable either. So there will be years where there aren't any matriculating doctors from their one and only medical school. And so they just really don't have the infrastructure or the staff to maintain a normal healthcare system.
Wow, cool. So could you please share with us, let's say, like a memorable or experience or a patient story that had a significant impact on you?
Yeah, I mean, there's so many to think about. It's a very intense experience working in Carnot, and I'll show some pictures of the hospital later to give you a sense of what it was like to be there. But it's a very rudimentary hospital with very little resources, and the patient population is extremely impoverished. So, I mean, some of the most striking cases I can think about were children in hospital with severe acute malnutrition. And I mean, these are just problems that we don't see in Canada. And so it's pretty, it's pretty difficult to see kids dying because they don't have enough food. I guess that's kind of the blunt way to put it. But, when you think about just how privileged most people in Canada are, and of course there's poverty in Canada, but you don't see kids dying of malnutrition. So the poverty is pretty unbelievable until you're actually there and see it with your own two eyes. One of the most difficult cases I had, I would say, was a kid who came in very, very sick. I think he was maybe around a year old, just with diarrhea and vomiting, gastroenteritis, something that is totally treatable, but families will travel 2 days by foot to bring their kids to the hospital. So by the time the kid got there, he was so unwell, and he died just shortly after coming to the hospital. And the mom, the local language there is Sango, and the project language was French. So I would communicate with the nurses in French, but almost nobody locally spoke French. So the patients would speak with the nurses back and forth in Sango. And after the kid died, the nurse and the mother were going back and forth, yelling, and the mother was of course very, very upset. And I asked the nurse, what is she saying? And the nurse said that the mom said this was her 5th child to die. So the infant and childhood mortality rates are just crazy. And I mean, these things stick with you, right? Because it's something you would almost never see in Canada. So those things I'll never forget.
Yeah, for sure. It is very upsetting to hear about these types of scenarios, and it's moments like these, right, where it shows how crucial the work of MSF is in terms of providing humanitarian assistance.
Yeah, I think the most fulfilling part of the job is knowing that you can do so much with so little. Most of these kids just need rehydration. The majority of the kids being admitted to the hospital just need rehydration. Some of them need antibiotics, some of them need anti-malarial drugs, but these are things that we can fix. But they're also things that are lethal without those few resources. So you can do a lot of good, you can save a lot of lives with not a lot. And it makes a big difference for the families and for the community. So that's, yeah, that makes it very worthwhile.
Yeah, I mean, just to think like how privileged we are in Canada, we don't usually think about these things because all of our infrastructure and health infrastructure is really robust. So it's really saddening to hear how in a lot of these countries that's not the case.
Yeah. Yeah. And like, I want to be clear, of course, there's poverty in Canada, and there are people who are really suffering in Canada too. And there's lots of work to be done in Canada. But yeah, I would say my experience in this particular place was just so extreme. Um, so yeah.
Okay, I think we can continue on with the MSF in CAR.
Sure. So yeah, this is just a bit of an overview of the work of MSF in the whole country. So you can see on this map here all the different sites that MSF has throughout the country. Last year in total, across the whole country, we did about 700,000 outpatient consultations, over 10,000 surgical interventions, over 9,000 people are receiving HIV antiretroviral treatment through MSF, and about 6,000 people were treated for sexual violence. And then focusing in a little bit more on Carnot. So this picture is a picture I took when I was landing in Carnot for the first time. So it's really in the middle of this green jungle. And then as you come down into Carnot, this is what you see, these just like red, brown dirt roads and huts. And this is what Carnot looks like. It's a city of probably about 100,000 people, although there's not really good census data, so it's hard to know. But this is what the city looks like. There's almost no real like concrete constructed buildings. It's almost all mud huts, which with thatched roofs. And even the nurses and some of the doctors are living in these mud huts. Like that's really all there is there, with very few exceptions. And of course, none of these buildings have electricity or running water. Most people access running water through wells, which have been dug mostly by the United Nations. But in their home, they don't have any running water. It's about 500 kilometers west of the capital city, or a 2-day drive. And a couple of days a week, there are flights. MSF has a plane, and the United Nations have a plane that come out to Carnot once a week. But otherwise, it's a 2-day drive to the capital. And the economy of Carnot now is mostly agricultural, but has historically had quite a fruitful diamond mining economy, and that still exists, but mostly people are just like subsistence living, farming in their yards and selling at the market, and then eating whatever their neighbors are selling at the market. These are some pictures. On the left here is a picture. This is like the entrance to the pediatric emergency department, if you can believe it. It's like basically just a corrugated shack. And then on the right here is the MSF headquarters in Carnot. So it's just like an office building. And the project in Carnot first started in 2009. There was a nutritional crisis. This is how many MSF projects start. There's some kind of acute crisis. So like natural disaster or conflict or famine, MSF goes to a place, starts with a very specific goal, like treating this acute nutritional crisis, as they did in 2009. And then over the years, they have become much more involved in the community. And now it's been 15 years since they've been there. And they've expanded from doing just nutrition to doing nutrition and HIV care. And now we manage the entire pediatric side of the hospital and some of the adult services. And then the government manages the surgical services, the maternity services, and MSF does basically everything else. The government does some of the lab management and stuff as well, but MSF does everything else. This project also supports some community health centers outside of Carnot. So in some of the rural peripheral towns, there are government-run community health centers, which are like, they're like just little mud buildings, basically. And usually there's a nurse station there. So patients can come in, be seen by a nurse in these places like 100 kilometers outside of Carnot. And then the nurse can refer them to the hospital. So MSF supports some of those surrounding health centers as well. This is a picture of the main building. And then the rest of the hospital is just kind of like little buildings around this main building. I kind of already touched on this in the last slide. So this is a list of the services that MSF manages, and then the Minister of Health manages the adult emergency department, surgery, and maternity. And then here's a picture of the inside of the pediatric emergency department. So you can see back here, there are like treatment tables. That's where we would do resuscitations or put in IVs, lumbar punctures, casting fractures, physical exam. And then this was my little desk here. I spent hundreds of hours sitting at this desk. And then sometimes strange things would happen. Like it was very common actually for people to come in with snake bites. And this picture is, I was on call on New Year's Eve. It was the middle of the night, and a family brought in their kid who had been bitten by a snake, and they killed the snake with a machete and brought the snake, but then tossed it off into this field near the hospital. So sometimes when you're choosing which anti-venom to treat with, it's helpful to actually see the snake. So me and the nurses and the family had to go out in the middle of the night with our flashlights in the field looking for this dead snake. So that just gives you an idea of how different it is from doing medicine in Canada. So yeah, to finish, I'll just talk about some of the challenges briefly and then some of the successes of this project. So I would say one of the key challenges is lack of knowledge about non-communicable diseases. So the nurses and the doctors there are really, really excellent at what they are familiar with, which is mostly infectious disease. So malaria, HIV, TB, all of the wacky diseases that come along with decompensated HIV or AIDS. But they are not as familiar with non-communicable diseases. So type 1 and type 2 diabetes, hypertension, strokes, epilepsy, heart failure. These are like my bread and butter here in Canada, but are not commonly seen in CAR. So this is a major challenge for the project because there are type 1 diabetics in the community. And then people, of course, come in with these other problems as well. And MSF is trying to address this by having like a consultant doctor there who is an expert in non-communicable diseases who can help teach the nursing staff and the local doctors about management of these things. So that's one thing. The other is a lack of local doctors, which is why I was there. So as I mentioned at the top, the only medical school in the country is a bit, it's just like, it's not reliable. So there will be years where they don't graduate a class of doctors because they don't have enough teachers or enough funding or whatever it may be. So it's very unreliable. There's a very unreliable flow of doctors through the training system. And then once doctors finish, it's very common to go somewhere else for specialty training because there really isn't a pathway to specialty training in the country. And then many of those people will just stay wherever they do their specialties. And then there are other doctors who just leave for a better life somewhere else. So there's a huge lack of local doctors. And that has been a challenge for MSF, quite honestly, to retain doctors on the projects because there's just not enough people. And there are kind of like MSF is a very protocolized organization. So we have like really particular medical protocols and then also like HR protocols. And the Ministry of Health is it's not organized in that way. So it can be alluring for doctors to work with the ministry because they have a little bit more freedom, maybe. This is just what I heard from my colleagues that I was working with, the local doctors I worked with. So it's hard to maintain doctors on these projects. Getting into more public health kind of challenges. One is treatment non-compliance among HIV patients. So even though MSF has been doing HIV care in Carnot for almost 15 years, there's such a lack of knowledge amongst the locals about how to manage HIV. And this is a tragedy because we can treat people with antiretrovirals and they can live totally normal, healthy lives. They can die at 100 of cancer and not die of their HIV. But there's like, you know, the people in this community, most of them, you know, have not, don't have an education. And so their health literacy is very low. And even if they do come to the hospital and get HIV treatment, a lot of them are lost to follow-up. They don't continue on with their treatments. And I would say this causes the majority of the morbidity among the adult population. So in our internal medicine unit, at any given time, we'd probably have maybe 30 adult patients, and probably 80% of them or more would be HIV patients who had not taken their, who had either previously not been diagnosed or who had been previously diagnosed but had stopped taking their treatment and now come in with these like weird and wonderful infections that are very hard to treat because the patients at this point have no immune system. So there's an enormous amount of morbidity and mortality associated with medication noncompliance. And MSF is working on this through, they have like a clinic part of the hospital where they follow patients with HIV. And so obviously education is like a huge part of that, but it's still, even after 15 years, that still is a major problem. And then the last kind of public health thing would be the use of traditional products. So again, the health literacy in the community is very low, and people have, you know, cultural, traditional products that they will give particularly to kids when they're sick. And there's not really, because there's no real like public health department in the country, there's really no like consensus around what products people are using. And so I couldn't even tell you what it is that people are giving. It's so variable from family to family. And like sometimes you would see mums at the hospital mixing dirt into water and like breaking bark into it and giving it to their kids. And they think that they're helping their kids. Like they're not doing this out of malice. They just don't know, right? So it's like a public health education piece that we need to work on. And unfortunately, it's often life-ending for babies. Like they just don't have the livers and the kidneys to manage these toxins that they get from these traditional products. And so it was very common for kids to come into the hospital in total liver failure. And we would suspect that the reason was traditional products. If you put a tube down their nose into their stomach, it would come out with like all this black junk. And unfortunately, a lot of those kids would not survive because we don't have we don't even know what the products are that they're getting. So we don't really have a solution for it other than to get it out of their tummies, rehydrate them, replace their sugar. They were often had low blood sugar because of their liver failure, but there's nothing really else we could do. So, talking a little bit about the successes. So, last year at the hospital in Carnot, we did over 8,000 consultations, over 6,000 hospitalizations. Probably 80% of those would be pediatric. Like at any given time in the hospital, there'd be about 30 adult patients and maybe like 50 or 60 pediatric patients. And then we treated over 600 kids for severe acute malnutrition. And that's just counting the kids who had malnutrition bad enough that they had to be hospitalized. There are other kids that are treated for malnutrition in the community. Over 440 neonates hospitalized. So we had a neonatal unit. And babies would come from the maternity ward for resuscitation in the neonatal unit. So many of these neonates would be babies that would not have otherwise survived birth because they needed resuscitation afterwards. And then 169 patients transferred to Bangui for higher level of care, mostly surgical patients. There's a lot of things they don't even have in Bangui. Like there's one CT scanner, but I don't even know if there's a radiologist to read the CT scans. It's like sometimes not working. They do have dialysis. They don't have things like angiogram. So if someone's having a heart attack, like there's no way to really treat their heart attack. So there were a lot of things that like, even if you could send the patient to Bangui, there wasn't really any treatment. Like there wasn't even anything more there that they could do. But what they could do is like complex orthopedic surgeries. So we would send patients to the MSF hospital in Bangui if they had complex fractures, open fractures, that kind of thing. So most of those transfers would be big fractures. And that's all I have prepared. So I'm happy to answer any questions.
Yeah, I mean, I think, those challenges were all very insightful, especially I didn't realize the health literacy in these countries was particularly low because of, the lack of an adequate education system, I guess. What sort of actions have you been taking or MSF been taken to sort of address these, like problems surrounding kind of lack of education, or maybe do you educate patients about maybe traditional medicine, traditional product uses?
Yeah, I think like there's three main ways that MSF is trying to manage this. One is just by talking to patients at the bedside, right? So like when you're there treating a patient whose parent has given them or someone in their family has given them a traditional product, we would counsel the families, about the risks of that. And try to, help them understand how dangerous that could be. The other way would be through the clinic. So this isn't really a good example for the traditional products, but like I mentioned for the HIV patients, if we identify that a patient has HIV while they're in hospital, they automatically get seen in the clinic before they leave the hospital. So they're like connected to the clinic, and they will already have their next follow-up appointment booked, say like 2 weeks from now. They'll be given the medications that they need to last them for that amount of time. And then they'll be connected with the nurses in the clinic who provide, like, are dedicated. They're there to provide patient education. And then there are also, MSF sets up peer support groups. So there are groups of patients with HIV who all meet together and talk about their diagnoses and share information. And so when a new patient is diagnosed with HIV, they get to be part of that group if they want to be. And that's a great way to have some like peer support and destigmatize it as well, because it's still very stigmatized. And that's a real barrier, is the stigmatization. So that's another thing. And then the last thing is community engagement. So MSF does lots of like community events. So for example, for International Women's Day, we had this massive community event with all the school kids in the kind of local area, and all the community leaders, and then people from the community are free to come and attend. And it's kind of a celebration, but it was also educational. Like there were presentations about sexual violence and HIV, and just trying to like educate people, but also destigmatize these things and make sure that people know like they can come to the hospital, they'll be treated with no judgment, and also help people understand that all the care that we give is free. Nobody has to pay for anything. So some people are afraid to come to the hospital because they think it will cost them, but it doesn't. So that's another piece. There's also like International AIDS Awareness Day. MSF throws a big community event for that as well. So we try, but the people in Carnot are just like a small fraction of the patients that we are actually seeing, because people will come from 100 kilometers away to the hospital. And so those people in the periphery it's really hard to reach them. And that's why like education at the bedside is so important, because you have to like, the right people use the term opportunistic medicine. It's like you might not see this kid again for a few years. So like, what can you do now to try to make sure that the family is well set up when they go back to their house a 3-day walk away, and make sure that they have the information they need in order to look after their kiddo. So none of these things are perfect, and obviously there's a long way to go, but I think yeah, those are the things that we can do and are doing in Carnot at the moment.
Yeah, that's really interesting and important. I just wanted to ask about like the destigmatization aspect. So,
Mhm.
do patients trust Doctors Without Borders, or generally the
Mhm.
hospitals to treat them?
Yeah, I would say by and large, patient trust is way higher in Carnot than it is in Canada. I think whenever patients stop taking their HIV medication, for example, it's not out of mistrust for the healthcare system usually. It's just out of like lack of information or misinformation. People will come in and say, like, here's a great example. Um, I had a patient who had TB and he also had a really bad wound on his foot. And at some point, after he was diagnosed with TB and given all of his TB medications, he went home, and like TB treatment is usually like 6 months. He went home, and instead of continuing to take his TB medications by mouth, he was worried about his foot. So he crushed up the medications and was applying them as like a solution to his foot. Um, and so this is not somebody who like doesn't trust the doctors or doesn't trust the hospital or doesn't trust MSF. This is somebody who, you know, isn't educated and doesn't really know much about medicine. And even though a nurse would have explained to that patient, like, you need to take this medication every day, we'll see you again in a month, all of those things. Here are like side effects that you can look out for. Here are reasons to come back to hospital. Like, these concepts are so foreign to some of these people. So they end up doing, pretty unusual things sometimes because they're just doing what they think is best. And it's not mistrust. But yeah, I would say the patients that do come to the hospital are like super trusting. MSF is like very, very well received in the community, by and large. And it's, the Ministry of Health charges for healthcare. So I think most people are very grateful to MSF to be there to be able to provide care for free so anyone can access it. And that's why people come from so far away. Even if they have a local hospital, they'll skip the local hospital and come all the way to Carnot because they know they can get care for free.
What were some of the most significant cultural differences you encountered, and would you say they affected your work and interactions with patients in any way?
Mhm. Um,
Uh,
yeah. I mean, I would say like the biggest challenge was language. Like I mentioned, most people, most of the patients didn't speak any English, or most of the patients and their families didn't speak any French. So I think about 20% of people in CAR speak French. Those are mostly educated people. And then the rest of the population just speaks Sango, which is a local language. It's not even on Google Translate. So it's very, niche to that country. Um, and so like to not be able to talk to patients is really hard. It's like very hard to communicate these things. These like kind of complicated medical things to patients or to comfort patients when you can't speak their language. So I relied entirely on the nurses to translate from French to Sango. And then, you know, they are very obviously this is just kind of like a broad brush cultural thing that I noticed. Not everybody's like this, but it's a very direct culture. Like people speak to each other very directly, and like from my perspective, it felt very like forceful and abrupt, but that's just like normal for them. So sometimes I would say to the nurses, like, oh, can you let the mom know that um like they shouldn't be giving traditional products to the kids, and like here are the risks. And then the nurse would like give this really animated, like very kind of like in some ways aggressive, or that was my interpretation of it. But like the moms wouldn't be reacting like it was aggressive. That was just like sort of how they communicated amongst themselves, and that's how they communicated to me a lot of the time too. So I think just like that is going to be a challenge anywhere that you go outside of your home culture, is like people just communicate differently, and what is totally normal and acceptable for other people can feel like really unusual. But after I figured that out, that was like normal, then you can just adapt to that, right? But I think the communication piece was the hardest part.
I see. Yeah, definitely. There's so many different languages, especially those like really niche languages and everything. It's definitely an important part of healthcare, but it's a lot of the times rarely talked about. A lot of people
Mhm.
don't understand it, so it's really interesting to hear about it.
Yeah,
Uh,
here's another interesting thing. Sango is like, it's a spoken language. It's not really a written language, although like people do write things in Sango now, but that's like a modern adaptation of the language. It's not traditionally a written language. So like, for example, having like a written pamphlet or something, most people don't read. And even if they do, um, there's like much um, variance in how people write the language down. So someone might write something in Sango and someone else might read it and garners totally different information than what was intended. So yeah, all kinds of challenges like that.
can you describe a particular challenging mission and how your team overcame the obstacles?
Yeah, well, this is the only assignment I've done so far. So um, I don't have any other missions to draw from, but I think I'm just trying to think of like what was the most challenging part of this project. Um, you like when you the MSF is really trying to ensure that the organization and the employees of the organization reflect the diversity of the populations that we serve, which is really great. But just like there are cultural differences between me and the patients, um, there were probably like 10 different nationalities of people working on this project. Again, 90% of the staff were locally hired, but then there were like 15 international staff, and we all came from different places. And so just like learning how to work with people who have a totally different communication style, speak, like French is not my native language. And for a lot of the other international staff, it's not their mother tongue either. So you're kind of like speaking not the language you're most comfortable in. And then everyone has like different ways of working and come from totally different backgrounds. And even medically, like the medical staff, we all have different training. Like there were 5 or 6 local doctors. There was me, there was a doctor from Mexico, a doctor from Burundi, a doctor from the Congo. So like we're all coming with totally different experience. And I think just finding a way to like work together and be productive, that is really challenging. But it can be really enjoyable as well. I would say like it's a double-edged sword. You get to exchange with these people who have totally different experiences and different expertise, um, and learn from them. But it's just like an added layer of complexity that you don't really have here in Canada.
Yes, totally. Speaking of which, do you happen to have any plans for future missions with the MSF, or what do you say that would be like your only one?
No, I'm like, I can't wait to get back out on an assignment. I want to do more. So, like, once you start working with MSF, the first project you do has to be at least 6 months, usually as a doctor. But after that, if you're interested, you can try to do more like emergency projects. So, Carnot obviously is a very long-standing project, but a lot of MSF projects are emergency projects. So, like, if there's a natural disaster, MSF goes in for 3 months and then leaves. Um, and so I'm trying to, just because of my life, like my husband is here, my family's here, I still work here as a hospitalist. I'm hoping to do some 3-month missions. So there is monkeypox outbreak in the Congo, which you may or may not have heard about. So I'm hoping I might be able to go to the Congo this fall to help MSF with monkeypox, but we'll see. But I definitely will do more projects. It's just with the emergency projects, you never know when they're going to come up. It's like they'll email you and say, you know, we want you here in a few weeks. Are you free? So I just like book my work here in Victoria a couple weeks in advance, always like waiting to see if something else will come up.
Yeah, it's great to hear how you're so committed to what you do, and it's really truly admirable of how you really want to make a difference in this world.
Yeah,
We
I feel
understand.
really lucky, you know, like I'm just very lucky that I got to this place in my life where I have the skills that allow me to help people. And it's really, it's a privilege. So I'm excited to be able to do it.
Hmm. We understand that working in a conflict zone or crisis zone, just like the car, is not easy. So, how do you say you managed the stress that came with working in such a different environment?
Mhm. Yeah, I think I got really lucky because, like I said, there were about 15 international staff. So we all lived together in a house, and I made some really close friendships, like one of the other doctors and then one of the nurses. We became like three really close girlfriends. And so we were like there every day at the hospital together. If things were going wrong, if things were going badly, we could call each other and then we'd come home from work every day and like debrief. So that was super helpful. I think I just got very lucky to like find people on the project that I became really close friends with. I'm very lucky because MSF now has internet access all over the world. So like 20 years ago, people would come with like um you know like stacks of books to read and like USB files full of movies and all these things because like they once they got to the project they had no access to the outside world. Like you could send a letter and it would take 2 or 3 months to get back to your family, and that was it. You had no contact with your family, you had really no source of entertainment or anything. um, but I'm very lucky to come to MSF now, you know, in 2023, 2024. I think almost all projects have good internet connection. So I could like video call my husband almost every day. I could like come home from work and put on a YouTube video and like put on a workout video. And so I feel like it's much less difficult now than it was even 10 years ago, but definitely 20 years ago. And then the other thing that I got to do is if you do a 6 month project, you are entitled to 2 weeks of vacation in the middle of the project. So I came all the way home, which was quite an undertaking. And then came home for about 10 days and then went all the way back. And for me, that was like super. A lot of people will stay kind of in the local area, like not in, you can't stay in car for your vacation because it's a security issue, but you could go to like Kenya or something and just take a vacation. But for me, it was like really, it was just such a stressful experience. And like, you can, like some of the stories I told about the hospital, like you can tell it's very emotional work. So it was really nice for me to be able to come home and like sleep in my own bed, eat familiar food, see my family, be with my husband, see my friends. And yeah, that helped a lot for the second half of the mission to be like a little re-energized.
Yes. So we were also just wondering, since like climate change and environmental problems are on the rise in recent years,
Mhm.
has that affected, global health, and is Doctors Without Borders adapting to new global health challenges presented by these like environmental factors?
Yeah, no doubt. One of the really interesting um, things that I noticed when I was in Carnot was that the local people were talking about climate change, and like they didn't talk about it in those terms necessarily because like these are people who like never went to school, right? But they would talk about how Yeah, like for the last 10 years, the summers have been way hotter and the rainy season hasn't been as rainy and like it's getting much harder for us to grow our crops. And so like just through like sheer observation, they know about climate change, um, even though it's not like a political discussion for them. So that was pretty fascinating, but also scary, right? Like, you know, here we have so many um like if there is a really hot season in California and they don't produce as many strawberries that year, okay, like us in Canada, we're going to survive because we have such a like redundant um uh like food source system. But there, like they just have what they're growing locally. So if there's a bad season, then there's a famine. So it's really high stakes. And just more globally for MSF, I would say climate change, it affects MSF's operations in two ways. One would be drought and famine. So making creating a need for care for malnourished kids, especially. And then the other would be natural disasters. So hurricanes, tornadoes, other um, other kind of extreme weather events that are increasing in frequency because of climate change. It just puts more demand on MSF. And I think um I shouldn't speak for MSF on this because I'm not like in the operational side of things at this point, but my impression is that MSF is trying to um kind of move away from these longer term projects that they have in places like Carnot and do more emergency projects. And I think part of that is just because like the need for these more emergent um, projects is greater now than it was before because of things like famine and extreme weather events.
Right. And from a more, let's say, personal point of view, how
Mhm.
has this experience changed or influenced your perspective on medicine and global health?
Mhm. Um, I think, I think I would say one thing is that until you go to a place like CAR that is so undeveloped and so impoverished, it one cannot imagine how bad it is. I had a lot of like, I had a fair bit of like life experience and travel experience and working internationally before, but I'd never been to a place as poor as CAR. And I just think most people have no idea just how bad it is. Just how poor people are, just how low the quality of life is, just how much suffering there is. Um, and so yeah, I think for me, it's just like, wow, there's like so much to be done. And again, a lot of the things that MSF is doing are really simple, like rehydrating babies. But that makes a big difference. Like the infant mortality is so high that it makes a huge difference for the society if we can keep babies healthy. So yeah, I think just like that takeaway of like, wow, there are still places in the world that are like hundreds of years behind where we are in Canada. Um, and then I would say, like somebody asked me the other day, was it a life-changing experience? And I would say it wasn't I wouldn't say it was a life-changing experience because like it's eye-opening and it's um tragic and it's stressful and it's all kinds of things. But like it does at the end of the day, like I come back to Canada and I'm like live in my nice apartment and I go to work and like I have my same family and friends. Like it doesn't alter your life in that way, but it is, I would say, life affirming. Like if you are somebody who goes into medicine because you really want to help people and you're interested in helping people in these like challenging geopolitical contexts, then having the privilege to actually go and do that is like total. And then to feel while you're there like you actually are effective, like you know, the MSF is doing what you want it to do and that you're able to be part of that system that is helping people, that is like totally life affirming. And yeah, it's a privilege.
Is there a message you would like to share with aspiring medical professionals who are passionate about making a difference in underserved communities?
Yeah, well, I think like I'm guessing most of the people in, or would you say most of the people in your organization are undergrad students or?
Oh, we are all high school students, actually.
Oh, high school students. Oh my gosh. Okay. Okay, well, yeah, that I think like um there's so much advice I could give about like medical school and everything, but I would just say two things. One is if this is what you want to do, you can do it. It's going to be a long process and there will be many speed bumps along the way and detours. But if you really want to do this, like I did, like since I was a little kid, my dad donated to MSF and we would get like quarterly brochures, you know, with pictures and little descriptions of like where donors' money was going. And I looked at those pictures and I was like, that's what I want to do when I grew up. And here I am. So if you really want to do it, you can do it. And the road to medical school and through medical school and into residency can be really challenging. And, you know, lots of people don't get into medical school their first try. And there's like lots of things like that that happen and kind of throw you off path. But if you really want to do it, you can do it. And then the second thing I would say is like, if you really want to do international work, you have to get around the idea that really meaningful work internationally is like long-term work. Like you can't go to a place for a week or 2 weeks, you know, and have a real impact. It's like you have to go to a place and commit and learn and be open to learning from the local people and become part of that hospital, part of that community for months. And then you can start to make a difference. So you just have to like plan your life around that, you know, like when I finished medical school and started residency and then finished residency. And then I was like, I don't know if I'm ever really gonna like get to do this Doctors Without Borders thing because like, how am I gonna fit it into my life? You know, you have like student debt that you want to pay off and stuff, and MSF doesn't really pay very much. So, there's all kinds of like logistical life reasons not to do it. But I think if you really have it in your heart that you want to do it, you just have to make room for it in your life, and then it's possible.
Yeah. So we're just wondering, like, basically a lot of your experiences are about like internationally, how we can help,
Mhm.
doctors in other countries. Since you are also working a lot in Canada, you're working as a
Mhm.
healthcare professional here. We're wondering, if you had any thoughts about the Canadian system as well, because
Mhm.
obviously we do also have an imminent shortage of doctors.
Yeah.
Obviously not to the same extent as in the CAR though.
Yeah, I would say like I have a considerable amount of cognitive dissonance around that because I know that there is such a shortage of doctors in Canada, especially family doctors. And I could open up a practice, a family practice in Victoria tomorrow and be completely full. And that would change the lives of 1,500 people. Like their lives would be made so much better by having a family doctor to look after them. So I feel a certain amount of guilt about that. I think what my husband always says to me is like, you can't do everything. You can't, like, even if you want to be somebody who makes the world a better place, like, you can't be a champion for climate change and a full-time doctor looking after patients in Canada and a full-time doctor working after patients internationally. Like, you can't do all of those things. All of us have the capacity to help in some way. And I think being a family doctor in Canada, especially in remote parts of Canada where there's limited access to healthcare, is like equally valuable to what I'm doing internationally. But I think the key thing to kind of overcome that guilt is to like look inwards and think about like, what are my skills? What am I good at? What do I feel passionate about? What like fires me up and motivates me to do a good job? And for me, working in that context, that gave me that feeling of like, I want to do more of this. I feel like I'm good at this. I feel like I'm well suited to it. And I think this is a good use of my skills. And then there are other people who are going to say like, I would never want to work in that situation. Like, I think, I love the idea of looking after a patient for their whole lifespan. And so I really want to have a family practice where I build like amazing relationships with my patients in Canada. And that's amazing as well. So I think it's a bit hard to reconcile those things, but it's all about like who you are and what your skill set is and what kind of lights you up. And so like my going somewhere else is not to deny that there are massive problems with the Canadian healthcare system. There are people who are really suffering here because they can't access healthcare. I see that every day in my work here because I work as a hospitalist in the hospital, and there are patients who come in and they've been suffering alone in the community for months because they don't have a family doctor. They have nobody to see. And so they wait until they get really sick and they come to the hospital, and that's tragic. And I mean, we could talk for hours and hours about how to fix the Canadian healthcare system, so I won't get into it too much, but I think, we just need more doctors, we need more nurses, we need more lab techs, like every single position in the hospital, from lab technician to janitor to doctor to nurse, like there's just not enough people, and we have an aging population. So, yeah, there's lots to be done, but I'm not necessarily the right person for that job, but I might be the right person for this job. So I think it can be easy to get overwhelmed, but got to pick a lane and commit to it, I think.
Yes, absolutely. Before we wrap things up for the day, any last thoughts you'd like to share?
No, it was great to be here. I did not realize you all were in high school. I thought you were university students. So I think it's really good that you're thinking about these things. And yeah, I hope that was like interesting and helpful in some way for you.
That was
Yeah.
super insightful. I really learned so much about healthcare situation in different countries, understanding the situation on the ground, sort of. You really painted a clear image in my head. And while it is sort of sad what's happening in a lot of these places, you know, people like you and Doctors Without Borders are taking the right steps to make sure that we are striving for global health equity.
This is Youth Advocates for Global Health Association, a nonprofit led by students passionate about joining the healthcare sector. Thank you again so much, Dr. Leishman, for joining us today as our guest speaker. And to our audience, thank you so much for joining us. We hope you've enjoyed our webinar session. Make sure to register on our website to attend our future events at yagha.org.
Perfect. Thank you. Have a good evening.
Thank you so much.